Thank you very much, Dr. Mohammed Bayoumi, for the nice introduction that I don't deserve. Thank you. It's a great pleasure, my dear professors and colleague, to be with you today. I shall thank the ECRA, the AFRA, and of course, my dear professor Mirvat Abul Maati for her invitation, and of course, for her great contribution in our heart failure program in our facility. So we will be talking, yes, about heart failure care programs and how to implement them and how to build them. It's, if you agree with me, it's a neglected entity of our cardiovascular care in many of the countries of the region, despite the high level of evidence and the wealth of data about their applicability and about their efficacy regarding patient outcome. This is the pity, since mounting a good quality heart failure program is not depending on high tech devices or expensive infrastructure, yet it's mainly depending on our understanding of the magnitude of the problem, of the obstacle and the need we need to tackle through an organization of a harmonized system, a documentation, and the continuous monitoring and data collection for a quality control for the sake of our patient. And of course, all that is fueled by the passion and the belief about what we can do with such programs for the sake of our heart failure patients. So it's only with the heart that one can see rightly. What is essential is invisible to the eye. I love to introduce my presentation with this quote. So the first pillar is understanding the magnitude of the problem of heart failure. So 10 facts we know about heart failure that reflects its socio-economic burden. The first fact is heart failure prevalence is high and much increasing through the years. We have now up to 26 million adults worldwide who are living with heart failure, and this number is rising due to the aging population, increasing prevalence of risk factors, and the improvement in our post-myocardial survival and care. It's a major and growing public health problem. In the United States, we have more than 500,000 new cases of heart failure each year. At the age of 40, 1 out of 5 individuals, right, 20% of the individuals at the age of 40 are at lifetime risk of developing heart failure. The second fact is the high rate of hospitalization. We know that these patients are in very high risk for hospitalization. It's the most common cause of hospitalization for patients aged above 65 years. 1 million hospitalization of heart failure is reported annually in Europe. And the most challenging and even more striking is the high rate of rehospitalization. We know that these patients enter into this circle of admission, discharge, readmission. More than 40% of all heart failure patients are readmitted for any cause within 1 year after their discharge for a heart failure decompensation. More than 25% of your patients on their discharge from a heart failure decompensation will be readmitted to hospital within 30 days. So these numbers are really scary. And this is regardless of the level of severity and decompensation or symptomatology of these patients. Means that the rate of rehospitalization remains high, whether the patient is in a NIHA class 1 to 2 or in a NIHA class 3 to 4. Fact number 4, this has a detrimental effect on their quality of life. More than 75% of the patient reports struggling with their daily activities. More than 60% have depression. More than 60% have difficulties for recreational sports or hobbies, which also augments their problems regarding their heart failure status. And over 40% will even struggle to have their daily routine activities with friends or family. Fact number 5, it has a significant economic burden. More than $100 billion were spent in 2012 in the USA, treating worldwide the cause of heart failure and the fact number 6, that this is mainly related to hospitalization. 70% of this cost is due to hospitalization. It's not about the treatment, it's not about the procedure, it's not about the medication, but mainly the hospitalization. So prevention or even reducing the rehospitalization rate will have a tremendous effect on the cost and the expenditure of the heart failure care. Rehospitalization means decreasing even more the quality of life of the patient and increasing the mortality. This is the base that we have all experienced and we are learning every day. The patient, each time he is decompensated, each time he is hospitalized, he is discharged weaker each time, with a decrease in the quality of life curve and increase in the mortality rate. As we see with the first hospitalization, the median 5-year survival decreased by half, the second hospitalization even more and more with each hospitalization. Fact number 8, high mortality rate, either by a decompensation or a circulatory failure or a sudden cardiac death. 50% of the patients with heart failure dies within 5 years. And this again is regardless of their severity or symptomatology of their heart failure. Patients with NIHA 2, NIHA 3, NIHA 4 have a high risk of mortality, either by sudden cardiac death in the lower NIHA class or by a circulatory failure in the NIHA 3 and 4. This high mortality rate even outweighs many of the 5-year survival of many of the severe cancers or scary cancers that we are talking and dealing in the healthcare system every day. Fact number 9, which is a good one, it has a well-defined goals of management. It's one of the fields of medicine, of cardiovascular specialties that are very well studied. We know that our goal is improving symptoms, preventing hospitalization, so reducing mortality. By improving symptoms, we are improving the quality of life of the patients, we are preventing their rehospitalization and hence reducing their mortality. This is stated wide clear in the European guidelines, same as stated clear in the American guidelines. So we have the goals clear, well studied, with high level of evidence, wealth of data to have a guide for our management. And the 10th fact, which is also a positive one, we know that heart failure management goals are achievable. Here we have a study showing the adherence to the guidelines. The more we are adherent to the guidelines and what's stated in the goals of management, the more the 6-month rehospitalization rate is decreased in a significant way. The more you are good in the adherence, the less is the mortality, the lower is the higher the rehospitalization rate. We have multiple medications that have shown a solid mortality risk reduction, starting from the ACE inhibitors, going to the ARBs and the ARNI, and the other pillars, including this elegant presentation by my colleague Hasib, who showed us the benefit now known with the SGLT2 inhibitors. So the ACE inhibitor, the ARB, what we see here is a reduction in the mortality risk and a reduction in the rehospitalization risk using any of these medication or even devices regarding CRT and ICDs. Even a simple early clinic, heart failure clinic visit post-discharge from hospital as early as 30 days will help reducing the readmission rate of our patients. Here is another proof of the achievability and attainability of our goals. Here the European registry, real-world data on over 12,000 patients, showing the more and more we are using the guideline medication in our patients. So we have to understand well these 10 facts, understand well the heart failure management goals that we would like to implement in our heart failure program. And I like this quote from the 2016, the previous guidelines. They said, and that was more than 5 years ago, no one would any longer dispute that by applying all evidence-based discoveries, heart failure is now becoming a preventable and treatable disease. This is a very strong and true phrase or concept, that now we have evidence-based procedures and interventions that if we apply it by the book, we can treat effectively a lot of our heart failure patients. So again, the goals are clear: improve the system, prevent rehospitalization, reduce mortality. Same goes for the American guidelines. So the concept is translating high standards applied in the controlled clinical trials into the daily regular medical care we apply for every patient in our clinics, applying the simple and advanced interventions proven to decrease the heart failure-related morbidities and mortalities. What we do, this is mainly the most important slide. If you apply these concepts, if you apply these procedures, you are coming with a good impact and a better outcome with your patients. So first, optimal medical treatment. And by saying optimal is using all the pillars now clear in the latest guidelines for these patients, use them together. We are no more escalating the treatment. We try to introduce the medication all together in order to attack and tackle this pathophysiology of heart failure from many ways in the same time. And most importantly, up-titrate into the target doses, up-titrate the medication up to the doses used in the clinical trials that showed the evidence and the great impact with significance when used by these doses. Control comorbidities and precipitating factors. And of course, as electrophysiologists, we survey our patients for the indication for either EP procedures or CIED implantation, CRT, CRTD, or ICDs. And of course, the optimum follow-up and optimization of these devices customized according to each patient. Invest the time to do so in order to get the best benefit out of the device implanted. Delivering therapeutic education and rehabilitation. And we love the word therapeutic education. It's not anymore just an information for the patient. No, it's an education. Means the patient must understand what you're saying, must be put into case scenarios, into situations, and help him and instruct him how to deal with each of these situations. And we love the word therapeutic that we use with our patient and we use with our team, letting them know that this is part of the therapy for the patient. It's not a neglected entity, but yet a cornerstone for the therapy and the treatment of these patients. This all to empower the patient with auto competences. Means the patient will, by time, by different sessions and multiple efforts of sessions, will have the experience, and you will allow him with auto competences to react into the different situation accordingly. Means you will give your instructed patient, your well-educated patient, the mean and the permission to increase some medication in case he felt more dyspnea or orthopnea or more lower limb edema. You will understand how the compliance and the tolerability with the medication goes with the patient. So empowering the patient with auto competences is a goal that we have to reach during the implementation of a heart failure program. Improving the compliance, and the compliance means the tolerability to the medication and to the procedures and to the instructions the patient, the lifestyle the patient is taking every day. And the word compliance is now put into our guidelines in the heart failure, put in the guidelines for the treatment of hypertension, the treatment of dyslipidemia, in every aspect of our cardiovascular care. It's not it's not dissociated from the tolerability and the compliance of the patient, because we are now dealing with the patient-centered care. Means you have to understand the needs, you have to understand the obstacles of the implementation of the optimization of the patient. You have to customize the care according to each patient need and profile and priorities. All that is done in a multidisciplinary team, of course, by interventionist, electrophysiologist, heart failure specialist, and of course diabetologists, and all those who attack the comorbidities and the precipitating factors, nephrologist, a nutritionist, clinical pharmacologist, and all the team. All that is designed in a heart failure care program in a unit, propagating and implementing all these measures all together, while continuously optimizing the system, collecting data for quality control and for the optimization of the care to these patients. So how are we applying all these in our heart failure care program? Our model, our component is a 7-clinic model. We mean we have an echocardiography clinic. Of course, it's a cornerstone for risk stratifying the patient and for categorizing the patient according to the different definitions of heart failure and types of heart failure. The 6-minute walk pathway, you have to have a pathway where the patient can walk for 6 minutes freely at his own pace, because the number you will be taking for his 6-minute walk test is used and useful for customizing the level of care during the whole journey in the heart failure unit or program. Physical rehabilitation, also giving the patient, the main concept here is giving the patient the will and the belief that despite he has this chronic disease, with implementation of the right medication, the right procedures, the right interventions, the right lifestyle, he will be able to have a normal physical activity according to his age. An EP or programming, CIED programming clinic, where we do the screening and we do the programming and the optimization for the devices implanted, or to screen the patient for an indication of implantation. A therapeutic education clinic and a therapeutic nutrition clinic. And as we said, it's one of the cornerstones to empower the patient with the auto competence and the information and the education he needs to modify his lifestyle and to have a higher compliance and better tolerability to the medication. All that, of course, is supported with good laboratory exams, and all these data are collected into the heart failure consultation clinic, where all the medical decisions are taken regarding the medication, regarding the needed procedure, regarding the optimization of all these aspects together in one heart failure consultation. So these 7-clinic model, either the patient passed by the 7 clinic in one day, or they are organized in multiple visits. This requires a firm administrative support from your team, who will be tracking each of your patient, having visited each of these services, for finally having a full heart failure consultation where he can have the optimization customized to his profile and to his needs. This is possible only by good documentation of what's happening. The documentation here is important to standardize the level of care delivered for each of your patients. It has to be standard, it has to be to the highest quality, and you have to document the emphasized elements you want to see. For example, this is our sheet for the echocardiography study. Of course, we are dealing with the structural exam, but also with what we call the ecodynamic assessment. All these measures that change over a short period of time, like the LVOT, VTI, reflecting the cardiac output, the IVC, the TAPSI, the tricuspid regurg, the transmitral flow, all these measures that we use in the optimization of our treatment maybe more frequent than any change in the LV ejection fraction that we look for more in a normal echo study. Laboratory exams, of course, to monitor, document every time and monitor the adverse events of the drugs, make sure the tolerability to the medication you're putting. And of course, we emphasize also on the dynamic measures, meaning the proBNP to risk stratify the patient, the sodium level, the renal functions, the potassium level, which is very important to monitor. The therapeutic nutrition clinic with a nutritionist, and this also is customized according to the patient needs, means we try to find the points that the patient is doing positively and try to consolidate it and try to see the obstacle and the points to improve during a nutritional session or a nutritional education. The data is important to be implemented in the daily practice of the patient. So we have a special diary for the patient to see or assess his implementation of all the concepts he has been educated about during a nutritional session in his daily meals and his daily practice. The same goes for therapeutic education. It has to be customized according to the patient needs. It's a full program with multiple topics. We make sure that the patient has the principal concepts or the principal sessions, but also variable sessions according to our follow-up to the patient and how we detect the obstacles he is confronting to try to address them during a therapeutic education session. Very important to educate our patients about the alert signs, the home monitoring, how to monitor his body weight, how to use it, how to interpret the data once he has measured his body weight every day or every other day. And of course, also empower the patient with a diary where he can put his inputs every time he is implementing these concepts. Of course, they are not doing this every time or every day, but we make sure that they have taken the pace to do it, and then it becomes a habit of their own. Every day they are implementing it. And we encourage them to even document their questions in a diary. Even we document their questions coming from phone calls or phone consultation to the hospital or to the doctors or to the clinics, because these will be the topic for further therapeutic education sessions customized according to the need of the patient that we have collected during the monitoring. Same goes for the compliance to the medication, and if he really understood the reason why he's taking each of these pills, we know that we need to have an 80% compliance with the medication to have the benefit stated in the clinical trials. This is a hard task to achieve, and by educating the patient and empowering them by understanding why they are taking so many pills and the concept behind each of these medication, that we are empowering them and helping them for the compliance. The 6-minute walk test, as we said, to risk stratify the patient and customize the whole test. And we have documentation for this too. And as I said, it's not about the session itself. It's about, yes, we use the treadmill. Sometimes we use the wireless monitoring sometimes, but the most important is the diary of the patient, that he is implementing these exercises and rehabilitation in his daily life, and he has really changed his lifestyle, and he has the belief that he can more and more do physical activities. The EP and the CIED programming sheet, of course, we optimize our CRT either ECG guided or mainly echo guided, and invest the time to really optimize the programming for each patient, customized to his own profile to get the best. And finally, all this data is briefed into the heart failure consultation clinic, where each patient has his card of identification, gathering all these data about the profile of the patient and the follow-up. And we have this very important sheet about the optimization of treatment. As I said, it's very important to up-titrate the medication up to the maximum target level as stated in the clinical trial. We even force our doctors, if they didn't optimize the treatment or up-titrate the treatment, to mention the reason why they didn't, if there were an obstacle regarding the lab of the patient or the tolerability or the blood pressure or so on. So these are the 7 clinic model, but not only the clinic is the part, but also a link about if any of our patients were hospitalized in our center or in other hospital. We try to gather data to understand the reason for this decompensation to be also tackled and worked upon during the sessions of the heart failure program visits, either hospitalization link or even nurse home visit, where our nurses visit the patient at home, making sure how they are dealing with the monitoring devices, how they are taking their body weight, how they are taking their medication, how they are even evaluating their limb edema. So we make sure they had the right knowledge and they are implementing the right knowledge. We also monitor our patients.
Dr. Hany, Dr. Hany, please. Dr. Hany. Dr. Hany. Yes. I think that most of the audience have got the idea you need to pass to them, that you have to go in the clinic in a systematic way. But actually, we are beyond the time. The schedule is just 2 hours, and now we are more than 3 hours. So I would like to conclude I would be very grateful if you could conclude it quickly to go to the next speaker.
Of course.
Thank you.
Yes. Actually, this would be the best slide to conclude. This is our work that we have published in the latest ESC, and showing how we have significantly, by implementing these measures I have mentioned, we have significantly improved the medication status of our patient, which was translated into a significant improvement in their pro-BMI through 1 year. And that has, of course, a significant impact in the outcome of the patient regarding 1 year hospitalization, the 30 days hospitalization, and the 1 year mortality. And thank you very much.